Good afternoon, gentlemen. Welcome to the webinar on transforming healthcare with information technology. Before we proceed on to the webinar proper, I would like to briefly touch upon CI Center for Digital Transformation, which is basically conducting such webinars in helping organizations and the industry understand the advantages of digital transformation in detail and IT for this case in particular. So before we go on to this webinar, I'll just briefly touch upon a few things which are very important and pertinent for the industry today. Okay, so whether ready or not, digital transformation is reinventing the business as we know. Every enterprise now faces a choice between innovation or extinction. Digital transformation is not specifically about IT or technology. It's about redefining your business strategy, perhaps even changing the corporate culture. To succeed in digital, a company should think of technology not just as a support function, but as a strategic competence. Digital transformation is not just about applying technology to business. It's actually about creating an entirely new business model on the backbone of technology. So transformation is actually the business transformation that we are talking of, which requires the business process transformation, which is enabled by technological transformations. We at CII conducted a small survey to understand the Indian industry's digital transformation index. We conducted the survey for both the service seekers as well as the providers. So if you see the view file here, the slide here, we find that there's a gap between what is required to be achieved to be considered as a threshold for Industry 4.0 for the service seekers. We find that there's a huge gap here. And even for the service providers, there is a certain amount of gap which needs to be fulfilled. So when we dig deep into it, what were the barriers for this transformation? We found that there was a clear vision. I mean, there was a clear backing not being supported by the leadership. And probably it was coming because of the unclear economic benefits, which could be directly linked to the digital interventions. Now, insufficient skill was also one of an important factor which played here. Then there were issues related to data security, data privacy, then lack of digital standards and various other things. And one more thing which came out clearly was lack of clear baselining and benchmarks. However, another important issue which came out was insufficient collaboration among technology providers and the business partners here. So to cover these gaps, we came up with the Center for Digital Transformation, whose basic purpose is to help Indian industry become globally competitive. The vision for this center is to be a center of international repute that enables continuous betterment of organizations through digital transformation. This center has been divided into 4 clear-cut verticals, which are digital transformation services, cybersecurity, skill building, and outreach programs. The details of the center is available on our website, cicdt.com. The center's first initiative was to launch a digital transformation maturity model, which we call DEXCEL. It was launched December last year in the summit. So this rating system will focus mainly on the 5 basic dimensions, which are strategy, structure and governance, business processes, technology, culture and talent, and business results. We are also into skill building, where we are helping organizations attain the required reskilling for various factors. The center has conducted various outreach programs like Digital Transformation Summit, and the awards were one of it. In the awards, we are facilitating the best practices in the digital transformation to help industry gain from it. Now, before we go on to the webinar proper, I would like to I take this opportunity to introduce our eminent speaker here, who is Dr. Krishna Ganapathy, who is Master in Surgery and Neurosurgery. He is Fellow of American College of Surgeons, Fellow of International College of Surgeons, Fellowship of Academy of Medicine, PhD. He is a past President of Telemedicine Society of India, former Secretary and past President of Neurological Society of India, former Secretary of Austrasian Society for Neurological Surgery, and past President of the Indian Society of Functional Neurosurgery, formerly Adjunct Professor at IIT Madras and Anna University. He is currently Professor at Dr. MGR Tamil Nadu Medical University, Chennai. So the list is very long. I would not take more time but I can assure you he has got a very long pedigree of the various degrees and credentials to his pocket. May I now request Dr. Ganapathy to please take on the webinar and start the proceedings, please. Over to you, sir.
Full screen. Hello, can you hear me and see the slide, please?
Yes, sir, we can see it and also hear you.
Fine. Okay, thank you, Colonel Zaidi and the CII for giving this opportunity. From the introduction, I gathered that CII's primary responsibility in conducting this webinar on transformation is to show a business model, as it were, for the deployment of information technology in healthcare. Now, this talk is going to be different in that I am an old-fashioned clinician, and I'm going to be on the other side of the coin. I'm going to suggest to business people like you that healthcare is totally different from any other factor. In fact, I personally don't like the word industry. I don't think we should really be considered an industry in the sense that the good old doctor-patient relationship still has a role to play. So in the next 25 minutes, I'm going to give you a bird's eye view, as it were, on how technology and technology alone can be used to solve, if at all we can think of solving, the Indian healthcare jigsaw. Now, India is a paradox. 1.3 billion people, we want to give them 24/7, high quality, equitable, sustainable quality healthcare. Not in the lifetime of my great-great-great-grandchildren will this ever be possible without using technology. I'm going to give you a few illustrations on technology-driven healthcare transformation. Now let's look at a case scenario. In terms of employment, this is a huge sector, fourth largest employer among all factors anywhere in the country, an impressive growth prospect, strong fundamentals and cost advantage, and a favorable investment environment. The healthcare industry is the only industry which is recession-proof. Even in 2008, when every other industry collapsed, the healthcare industry did not. Please remember that even before you are born, when you are inside your mother's womb, and even after you leave the world, you still require or still can use the services of the healthcare provider. Now, healthcare as a whole can be divided into hospitals, pharmaceuticals, diagnostics, medical equipment, medical insurance, And last but certainly not the least, on which I'm going to talk to you in detail, is telemedicine or remote health care. Each one of these verticals is literally $1 billion potential even in our country as it is now. Now let's go into a little more details. E-health, digital health, M-health, ubiquitous health or mu health as I call it, all these are synonyms for the practical meaning is remote healthcare or telemedicine or telehealth. Personally, I would prefer the word telehealth to telemedicine. Medicine implies diagnosis and treatment. Those days are gone. Even a dividend declaring company, a corporate hospital group like the Apollo Hospital has realized that there is better ROI when you concentrate on keeping people well. In other words, promoting wellness, making them healthy, using sophisticated state-of-the-art technology will be the major challenge in the years to come, not diagnosis and treatment. Now, e-health comprises every one of these synonyms, which is self-explanatory, which you see on the slide. Now, let's go into the details of this. Digital healthcare ecosystem. As I said, even from pregnancy, from antenatal, even when you're inside your mother's womb, healthcare really starts. And during infancy, during childhood, during adulthood, not just diagnosing and treating, but so many factors. You can see here, remote monitoring. Never in the next 50 years or even 100 years will we ever have enough brick and mortar hospitals. We will never have enough doctors, nurses, paramedics, hospital beds, medical colleges, whatever you call it. However, we have already touched the 1 billion mark in terms of mobile phones. 35% of the population of India today have smartphones, and the number is ever increasing. In the next couple of years, internet connectivity is going to penetrate into rural India, which has already started. So I propose that we need to exploit this fantastic exponential growth of information and communication technology to make distance meaningless. Today, ladies and gentlemen, geography has become history. It doesn't matter where the doctor is. It doesn't matter where the patient is. And I will show you this with examples. Insurance is, of course, a major part of the healthcare system. Pharma, we have healthcare education, emergency response. I recollect what the chief people officer, knowledge officer of NHS, the world's largest medical healthcare organization, once told me a couple of years ago, Sir Muir Gray. He said, it is far better to educate people, promote health literacy. Promoting health literacy is far better and more meaningful than prescribing antibiotics or doing surgery. If I were the Health Minister of India, I would allot a significant percentage of the health budget to promote health literacy and to prevent totally preventable conditions. This can be done today using technology. Now, I had actually made this slide several years ago, but I think it is still relevant. Today, we talk in terms of standards and regulations, interoperability, scalability, security is as relevant in EMR, hospital information systems, and so on. You can see on the left and on the right, today we don't use just the phone. Fax, of course, is almost obsolete. Today we use emails, we use chat, we use chatbots, we use robots, and this is how we are going to touch 1.3 billion lives. Preventive care, curative care, emergency care, teleradiology, healthcare analytics, big data. Big data analytics is particularly useful in the field of healthcare. Now, the digital health landscape, ICT would be called the third pillar of the healthcare industry. You can see we are talking of wearables, sensors and wearables. Just show me this, please. I need to see that. No, show me that. Okay, doesn't matter. You can see sensors and wearables, and you can, which is very, very important, health, IT, medical imaging, big data, and so on. Now, a study done about a year ago showed that almost 38% access health information online. And of course, the single largest use of Google, interestingly, is to get health information. 25% use health apps. This was several years ago. Today, the number is much, much more. Online support groups, patients themselves start forming their own electronic support groups, and this has totally changed the way healthcare is. Industry shifts. I think basically that is what the attendees of this webinar would like to know about. We are talking of payment innovation. At the end of the day, it's vitamin M. Unless a doctor is reimbursed, unless a healthcare provider is reimbursed, he is not going to fully involve himself. And innovations in payment have made this extremely simple today. From sick care to wellness, we are again talking of integrated care delivery models. Until recently, without the use of IT, everything was in silos. A patient almost never goes to the same doctor, to the same department. Today I live in Chennai, 3 years later I may live in Ahmedabad, in Mumbai, somewhere. Unfortunately, I don't have access to my medical records, and many of the investigations have to be repeated. We need to disinherit the old legacy systems. We need to start building a new legacy system where we have what is called MPHR, that is, a personal health record is available, is stored in the cloud, high security, and just using a smartphone, I will be able to download not just the laboratory investigations, but even the histology, even what I see under the microscope for a biopsy report, and all I have to do is to just give the link to the new doctor whom I go to. This simple thing like this will totally revolutionize the continuity of healthcare. Healthcare, ladies and gentlemen, is not a single isolated event. It is a continuum from the cradle to the grave. Ideally, every single encounter with a healthcare person should be available in real time. Information-centric decisions. A medical doctor is not God. He depends entirely on information. The more information I have, the more reliable information I have, the more data I have, and if I have assistance, like, for example, artificial intelligence, artificial neural network, machine learning, deep learning, etc., I will be able to extrapolate what is today found in the literature to the single individual patient who is in front of me. An empowered citizen makes all the difference, and today the care team also needs to be empowered. This slide may appear very complex, but I'm just showing you as an illustration of how today one can make an error-free medication ecosystem. I do not know how many of you know that the third largest cause of death in the United States of America is not cancer, not stroke, not road traffic accidents, as you would think, but doctors. In other words, iatrogenic or preventable death is what occurs. It is entirely because of information and communication technology that we are able to analyze all this. Drug interaction produces severe morbidity in addition to mortality. Adverse drug reactions. It's humanly impossible for any doctor to remember all the time that this particular woman's kidney functions are impaired, that she could be pregnant, that she had taken this particular drug 10 years ago and she had a subminimal allergy reaction to that, and so on and so forth. So today we have very excellent user-friendly complex systems like what you see, where technology applications, these promote medication adherence, remote patient monitoring, reminding elderly people. You have smart containers, and with these smart containers, you get a reminder that you have forgotten to take your medication in the morning, automated, semi-automated medication dispensers, etc. I could go on and on, but this is just to show you how there's a tremendous body of drug knowledge, and this itself can significantly reduce morbidity in any hospital. I would like to spend a minute or two on AI. Personally, I don't like the word A. I think there's nothing artificial about it. I think it's an extension of God-given natural intelligence. It should rather be called extended natural intelligence, native intelligence. The A, instead of artificial, it actually represents augmenting, amplifying, accelerating, and assisting God-given intelligence in an ambient milieu. AI is the synonym of using supercomputer systems to perform tasks that normally requires integration of the various aspects which together constitute human intelligence. Example, visual perception, speech recognition, decision making, translation between languages, etc. About 2 years ago, I wrote an article on artificial intelligence in neurosciences as a neurosurgeon, but purely a clinician's perspective. I did not talk about the complexities of AI, but instead I showed how AI could help make a neurosurgeon, a good neurosurgeon, a better neurosurgeon. But remember that technology is only a means to an end. It is not an end by itself. It is only an enabler. At the end of the day, you still require tender loving care. The doctor still needs to establish a rapport with the patient, and I'm very unhappy if the day comes when AI will replace a doctor. I'm very happy that Niti Aayog, even 3 years ago, have already realized that artificial intelligence is going to play a major role in the healthcare industry. I am told that the 150,000 wellness centers contemplated in Ayushman Bharat all are going to be run with AI, and these wellness centers will also have a telemedicine center so that a less than adequate endowed healthcare provider will instantaneously be able to virtually contact specialists through telemedicine all over the country. So, in fact, a white paper has already been brought out on national strategy for AI only in healthcare. The medicine of tomorrow, actually it is not day after tomorrow, it is tomorrow. I'm sure in my lifetime, I will see predictive, personalized medicine, precision medicine, participatory medicine, and preventive medicine. This 5P medicine, as it is known, will obviously be data rich. It will have at least 41 zettabytes, which is 410 trillion gigabytes of digital information. Unfortunately, 80% of this is unstructured, and this is where AI will try to make meaning out of it, and what today is an unstructured data will in the next couple of years certainly be structured. There is a resistance to change among the healthcare providers. There is a fear that AI will take over jobs, but this is just not going to happen. Now, where do we store this voluminous data? We obviously store it in the cloud. We are not going to have laptops and desktops and with capacities of several terabytes. Everything is going to be stored in the cloud. Personal health devices, I'm afraid that this is going to be overused, that this is going to be misused. But if used only when clinically indicated, I think it will make a tremendous difference. Today, it is possible to check your blood sugar non-invasively, not even a drop of blood, by just having a sensor under your watch. It is FDA approved. We can check your blood sugar. But what I'm worried is that I personally would not like to have 100 blood sugar readings a day, because I think it will only complicate the management. So please remember, at the end of the day, it is clinical judgment and wisdom which is important. The new business is wearable technology. I somehow get the impression, maybe because I belong to the BC era, before computers and before Christ are one and the same. I was the last neurosurgeon in 1980 who was trained even before the CT scan came. Maybe I am biased, but I get the feeling that we are now in a stage of transition. We have developed solutions, fantastic solutions, and are now going in search of problems. The technology people develop a solution and then go in search of problems so that there will ROI on those solutions. It should be the other way about. The good old-fashioned medical doctor should come to you, should come to CII and tell them, look, I want this, I want this, I want this, can you help me? Instead of the other way about. But again, I'm sure this will settle down. IoT in medical care is also of tremendous business potential. We are talking of sensors. The cost of sensors are plunging. Medical sensors in very soon will cost hardly 2 rupees or 3 rupees. Data processing analytics, these sensors will be independent, will be intelligent sensors and smart sensors, and they will give you quality, privacy, affordability, and obviously tremendous economies of scale. EMR, hospital information systems, clinical support systems, this can be subdivided into radiology, laboratory, PACS systems, registration, housekeeping, etc., etc. Now, you name it, running a hospital is a mega project. Ask any CEO of a hospital and he will tell you. The medical doctor hardly knows what are all the things which are happening in the background. Starting from recruitment, payroll and benefits, appraisal, time attendance, exit management, sales management. I mean, you people are all experts in this. Appraisal, credentialing, employee database, referral doctors database, etc., etc. These thousands of data points today can be simplified by using appropriate technology. The World Health Organization just last year, 6 months ago, has started a new division called Digital Health. And I'm very happy that I am also one of the 5 people from India who have been selected to be on the World Health Organization panel of digital healthcare. And hopefully in the next year or two, the new digital healthcare division will make fundamental contributions to better the healthcare system in the country. Now, what will the digital healthcare division do? We will ensure effective coverage, accountability for this coverage. We will ensure continuous coverage and so on. A preliminary 150-page manual has already been brought out. I'm going to spend the next few minutes saying what India has done. Everybody complains about the government, and here you see some examples. Ministry of Health and Family Planning. It is amazing what they are doing. I honestly think we are not too far behind the most advanced country in the world so far as healthcare information technology is concerned. We have tools and technologies, education and training, national releases, implementation support, advisory and consultation. I also happen to be associated earlier with the Department of Science and Technology and now with the Department of Biotechnology. I have spent the last 4 years in evaluating almost 500 digital health projects, which BIRAC, the Bioindustry Research Assistance Council, a standalone unit of the Department of Biotechnology funds, and it's absolutely thrilling to see 20-year-olds and 25-year-olds entrepreneurs who all of them are called CEOs on what an amount of technology they are bringing in, and we have funded 500 digital health projects, and I think many of them have got patents, and in the next 2-3 years you are going to see that the Make in India, Digital India is not just a term but is actually going to happen, and I am confident that in my own lifetime I will see all this being exported to other countries in the world. I've just given you a few samples of the sort of projects which we fund. This is again a snapshot of what is used at Apollo hospitals, corporate relationship management, a doctor's workbench, nurses' workbench, and so on. ACE at 25 is clinical excellence. Now, just 25 parameters have been chosen. This is across the 71 Apollo hospitals. This is updated in real time. And after introducing this a couple of years ago, we are able to, the IT wing of the Apollo group is able to precisely find out where something goes wrong, and more than that, complement departments. See, with 10,000 beds, this is a mega institution, but with this technology, they are able to find out what went wrong. Is it catheter related, urinary tract infection? Was a complication rate following TURP slightly more than the world rate, and so on and so forth. So we are able to compare this and promote clinical excellence. In conclusion, I would just like to share with you 2 slides, and this was what Himachal Pradesh, Kaza and Keelong in Lahul and Spiti at 14,000 feet height. I have gone here twice. I have an absolutely wonderful team, and you can see before we went there, this was the way healthcare was being provided. But thanks to information and communication technology, we have totally changed everything. And in the last 4 years, we have given more than 19,000 consultations and almost 1,000 tele-emergencies. My consultant appears on a screen within 30 minutes when the external temperature is -25 degrees centigrade at a height of 14,000 feet, landslides, the whole valley is cut off from the rest of the world. But we have a BSNL VSAT dedicated exclusively for this. So this is the power of technology, and these are public-private partnerships, and we are very happy that we now have several public-private partnerships throughout the country, and I think it's only a question of time before the other state governments and the government follow suit. Our major projects are in Andhra Pradesh, and we have just covered 10 million patients who have been provided remote healthcare in the last 20 years. The majority have been in the last 2 to 3 years. One needs to be future ready. I would never have thought that I would really see drones in action, but we are in the final stages now. Hopefully by next year, we will also have pilot projects being carried out where drones are being used not only to deliver products, but to collect samples as well. So what is my take-home message? My take-home message is that healthcare is totally different from any other business. Here you exist. In my opinion, the healthcare industry, as you like to call it, exists only for patients. And in 2020, we are talking of e-patients. Today, the e-patient is an electronically equipped, enabled, empowered, expert, engaged. And today, when a patient comes to me, believe me, he knows almost as much as I know about his specific condition, if not more, because Professor Facebook and Professor Google have ensured that whatever information I have stored in my brain is readily available and possibly much more reliable. Patients don't care how much you know. All the letters after your name, all the papers published, all your webinars and presentations, they don't care a damn about it. They want to know how much you care for them. Unfortunately, I have a feeling that this is slowly going away. We are witnessing the depersonalization of medicine, the dehumanization of medicine. This should be avoided. Technology is a means to an end and not an end by itself. Healthcare is very personal. It is very hard to feel your experience was excellent when those treating you don't introduce themselves or make eye contact or say what they're doing to you and why. A robot may have fantastic precision, but when a robot tells you that you need an open heart surgery, you have got dozens and dozens of questions to ask. Today's doctor is not trained in communication. He does not know how to talk to a person, how to convey a very serious program. How do you tell the family of somebody that their husband, their father, who is now in the ICU, is unlikely to survive? This is what we need to concentrate on. It is not process and technology, people who also matter. You're all familiar with the Gartner Hype Cycle. I think 2020, we are in the peak of inflated expectations. The buzzword is AI. Everybody talks about digital healthcare. Everybody talks about all the fancy terminology we use. This is necessary. It's absolutely essential. But I'm sure that in the next few years, there will be a trough of disillusionment. There will still be a role for the good old family physician, for the good old general practitioner who is wiping the tears of a person who is sick. then comes the slope of enlightenment, and finally there will be a plateau of productivity. At the moment, we are in the peak of inflated expectations. I would like to conclude by being a little personal. 20 years ago, I started telemedicine as a hobby. Digital healthcare, e-health, m-health, i-health, ROI, etc., were unknown then. It has been a wonderful journey. It has been very thrilling. And I'm equally delighted that in 21 months from now, in ISRO, we'll be sending from Sriharikota, totally indigenous, India's first 3 Waimonauts, as we like to call them, who will be in low Earth orbit for 7 days, providing remote healthcare outside the Earth. Even though it is only going to be for 7 days, I think is the ultimate in telemedicine, ultimate in digital health, ultimate in remote health. I would never ever have dreamt that there would be a symposium, a 3-day conference on human spaceflight and exploration conducted at Bengaluru, where there would be delegates from all over the world. This, ladies and gentlemen, is the India we talk about. India is no longer a third world country. They're no longer a developing country. We are an emerging economy. It is 73 years since we became independent. Challenges are what makes life interesting, but overcoming them is what makes life meaningful. The stage has now come where we need laws, we need rules, we need regulations, we need compliance. We have become of adolescent age, we have become young adults so far as digital healthcare is concerned. I would like to thank my wonderful team. As I said, I started telemedicine as a hobby in 1998. Today, we have almost 3,000 people working in the remote healthcare division, and Vikram, headed by Vikram Taplu, CEO, and other senior managers here. You can see it's a wonderful team I have. The slide on the left is how ISRO started. It actually started. This is how rockets were taken in Tumba on a cycle. This is how we too started. And I'm sure in 2 years from now, we will be providing, hopefully, healthcare, not just in the sky is no longer the limit for us. And so this is the future. So thank you once again. If there are any questions to answer, I'll be happy to take them. It is not the strongest of the species that survives, not the most intelligent, but the one that is most responsive to change. I don't know whether the video is playing. Is the video playing on the right side? I can't communicate. Video.
Yes, it's playing.
Okay, great. Now, I think I deliberately put up this. If you watch for another 20 seconds, when I was a medical student, a postgraduate, a teacher, assistant professor, etc., I was taught that when a newborn child cries, it's because the child is hungry, child needs to be fed by the mother, child has ants, has fast urine, and so on and so forth. But look at this photograph. It speaks for itself. This baby, hardly 6 months old, has already become familiar with a smartphone. Look at that feel, look at that body language. It speaks for itself. The child is delighted. Intuitively, it starts using the smartphone, just a few months old. And when the phone is taken away from the family, you will see the child starts crying. And when the phone is restored, the child is once again happy. So this is the world of the future. So let's accept it and use it nicely for healthcare. Thank you once again for this opportunity.
Thank you, Dr. Ganapathy. That was a very, very interesting presentation. And I'm sure the people who have registered for the webinar would really benefit from this. And while I would like to say that we would be sharing the presentation, we have some questions from some of the participants, and I would request some of the others to also write in their questions so that we will take them one by one. Now, the first question is from Mr. Nishant Nambiar. He's asking you, doctor, that how do we build a standard systems in Indian context without a standards in place?
The answer to your question is, if we wait for everything to be in place, it's not going to happen for the next 500 years. You cannot learn swimming by a postal course. Get into the water, drown, and then that's the only way you will learn to swim. So I would strongly suggest go ahead and start do it. The standards will come one by one, and only if you get into the water, you will know what are the difficulties, what are the problems, etc. Having said that, I don't know what are the standards you're referring to, but many standards are also already available. Guidelines are available. They may not have been notified. They're not yet legal. The TeleHealth Act of India, Digital Health Act of India, etc. All these are on the anvil. They're not yet been passed, but many standards are already available. Technical standards for telemedicine, EMR, hospital information systems, hospital architecture, all these are already available. It may not be implemented or enforced because we don't have, unless we have a carrot and a stick, it's difficult to do that. But I don't think the lack of 100% standards easily available to you instantaneously should deter you from starting on what you want.
Thank you. Now, the next question we have from Mr. Chandrasekhar. He's asking you, is there any cost model involved in consulting remote patients, or is it a CSR program from your side? Is Apollo open for tie-ups with digital healthcare centers sponsored by the government?
We have no single size fits all. India is too big a country. We have all models. Our major clients are the government. We do almost 4,500 consults every day on public-private partnerships. So the government calls for a tender. We have successfully got the contract. There are very few organizations which can do what we're able to do. So they give us a lump sum of money and roles and responsibilities, deliverables, terms and conditions, blah, blah, blah. The patient does not pay us. The government pays us on very strict enforcement of deliverables. So that is one model. Second model we have is we have a very big MNC. For the last 4 years, we have been doing a major CSR project from them. They are so happy. They have been increasing the funding every year, and we have just covered almost 1 million, I think 9.8 lakhs or something people in the last 4 years in 6 different regions of India. We do technology-enabled camp screening for preventive diseases. The third model, of course, is our own franchisee centers. We are more than happy to collaborate with, we have a fourth model. Third model is University of Pittsburgh, for example. We run a center for them in a very remote tribal area in Gujarat. Like this, we have several organizations who fund the whole project. Projects are run in their name actually, but it is done by us. The fourth way we do it is our own patients, review patients. As you know, all the big Apollo hospitals, particularly Chennai, where I am located, 80% of our patients come from northeastern India, from outside India, various parts of India, etc. So review. I think in 2020, it's a crime for a cardiac surgeon to make a 3-month-old baby who has had an open heart surgery come all the way from Mizoram so that he can see the scar or auscultate. So we encourage as far as possible, we discourage as far as possible patients from coming again to the hospital. 80% of our telemedicine consults are review patients, old patients who already have undergone treatment in one of the hospitals.
Okay. Thank you, Doctor. The other question that we have is from Mr. Siddharth Gupta. He's asking you, under the Public Data Protection Act that restricts the commercialization of data, how will the government derive monetary value from the healthcare data for insurance companies, payers, farmers, and other stakeholders?
I think that question must be asked to the select committee of the cabinet rather than me, sir. I honestly don't know the answer, but you have raised a very important problem. Yes, to the best of my knowledge, these are all matters which we are aware of it. The people concerned are aware of it. It's under discussion. This is going to take some time, but you're absolutely right. This is one of the issues which need to be solved. I don't think that, to the best of my knowledge, I don't think it has been addressed yet.
Okay. So the next question is, how important is data-driven method to be adopted in healthcare setups for transformation?
That's a very loaded, double-edged question. The answer is very difficult to answer that question. From a public health point of view, If I were the health minister or the health secretary or somebody in charge of the health of millions of people, this data is critical. You cannot do any planning, policy planning, you cannot do anything without data. But having said that, in one of my slides, if you remember, I spoke about 5P medicine, I spoke about personalized medicine. Just like your biometrics, just like your fingerprint, just like your retinal scan, no single patient responds even to paracetamol. Each one of us are slightly different from the other. So a good clinician should be aware of this, and you should not extrapolate the data available. Statistics have no meaning at all. See, according to statistical analysis, you can say 17.32% of men above between the age of 50 and 54 may develop diabetes mellitus after 9 months and stuff like that. But for the individual patient in front of you, you have to use your own clinical wisdom and judgment. So the answer to your question is data is absolutely required for policy making to decide on the future in public health, but data should be kept in the background. The final decision should be between a doctor understanding not just the disease, but understanding the socio-economic background of where the patient comes from.
Yeah.
Okay. Thank you, Dr. Ganapathy. We are receiving a lot of appreciation for your presentation. That's why the questions are also pouring in. Now, the next question is, how do you see the use of drones in healthcare in India? What use cases can we start working on? This is from Manish Sharma.
Okay, that's again a very practical, down-to-earth question, and I'm very happy that the Civil Aviation Department have, after several years now, I think it's called Drone 2.0. The regulations are almost in place. Of course, they need to be fine-tuned. Obviously, they're almost in place. So, if anybody is serious about it, I think it can be done. Two, immediately the use of drones would be to as in Rwanda and as in many countries in rural Africa, would be to drop blood. I have spent some time in a drone factory. I've seen how drones are manufactured, how they take off land, etc., etc. So one of the use cases, immediate use case would be, see, for example, our own center in Himachal Pradesh. Now, it is very difficult to provide health care for a small population. If there are only 10,000 people, the chances of somebody requiring blood occurs only once in 2 months. But for that person, at that point of time, it's a matter of life or death. It is humanly impossible to have a blood bank which distributes 5 units of blood in a year. So for such cases, and unfortunately, we have tens of thousands of clusters in India with small groups of people where you cannot have blood bank, you cannot have vaccines. Now, vaccine storage, for example, 20% of vaccines in India are spoiled, are destroyed, are ineffectual, because by the time they leave the factory in a city or in a suburban area and then finally go to the village, it is impossible to maintain the temperature at precisely what you want. So you can have vaccination camps today in 25 minutes to 30 minutes as the crow flies. The most modern drones can travel 80 miles, 120 kilometers in about 30 to 40 minutes. Of course, the payload is still restricted to 2 kilograms, but even that is good enough. You can take at least 100 vaccines. It is so simple today. Take 100 vaccines, just drop them in a parachute, come back, take the next load, and so on and so forth. So immediately, similarly, all drones can be used to collect samples. Now, it's impossible to have a microbiology laboratory when you have a sample for testing once a week or once in 2 weeks. There's a minimum number which you require every day. It may sound ridiculous, but it's a fact. Urine for culture sensitivity, blood for culture sensitivity, difficult tests which can be done. All these, the blood can be drawn out by a paramedic, by an ASHA worker. And the blood, instead of sending it 300 miles across, 150 miles across, you can have a drone collection center. A drone can come twice a week, once a week at a specific time and collect samples. So this is how I see it at this point of time. Later on, of course, drones can be used within a big hospital. Our hospital in Madras, for example, Apollo Delhi, if you look at it, it's almost 1 kilometer from one ward to another ward extreme. So there you can use a drone to deliver within the hospital and so on.
Thank you, Dr. Ganapathy. That was a very good explanation of how drones can be used. Now we have another question from Dr. Raymond Tiwari. He's asking you, what disruptions would AI bring in radio diagnosis, especially in CT and MRI reporting?
Okay, the good question. Here we are not talking of the future, we are talking of the past. There is enough published data in huge studies, meta-analysis. I'm talking of 100,000 images being reported by AI compared with 10 of the world's leading radiologists, etc. Specific studies have been done on pneumonia, where CT of the chests have been diagnosed, MRI of brain tumors and pancreatic tumors, prostate ultrasound. These four, and specifically I'm able to recall, where they have shown that deep learning, machine learning is able to pick up patterns, is able to pick up shadows which are not picked up by even the most experienced radiologists. The percentage is, let's say, 94% AI, it's only 89% or 88% human beings. So the diabetic retinopathy, though it's slightly outside your question, diabetic retinopathy studies done in India, Arvind Eye Hospital and Google, huge numbers. We're talking of tens of thousands. We're talking of 20,000 retinal images totally seen by a machine, and their results are slightly better than the most experienced retina specialist. So there's no question about it. In imaging sciences, in radiology, AI is going to take over. Now, having said that, my favorite sentence is, AI will help a good radiologist become a better radiologist. AI will not help a lousy radiologist become a good radiologist. Please understand that the AI is an application, and therefore a good radiologist who normally would take, who can see only 10 CT scans per hour, with AI, he will be able to see 20 scans per hour.
Next question. Now the next question is, should government mandate use of technologies including EHR while treating patients? This is from Mr. Kishore Vicaria.
Right, EHR, yes, I totally agree. I was a little worried when I heard only the first part of your question, should government mandate technology? Then the answer is a violent no. But if it is technology for EHR, the answer is yes, yes, yes. You must have a carrot and a stick. A country like the United States, I'm sure all of you know that Obama 6 years ago, he said, I'll give you $4,000 per year as an incentive to doctors. If you use it in the next 6 months. If you use it after 1 year, you will get 3,000. After 2 years, less. After 4 years, you won't get anything. After 5 years, if you don't use it, you will be fined. So it's a fact of life. None of us are going to pay income tax if it is purely voluntary. There has to be a fear of God. There has to be a fear or an incentive. So unless there is a carrot and a stick, nobody is going to use EMR. So I think this should be done, because it will take at least 10 years for it to implement it. So I'm surprised that they have not yet made it mandatory.
Thank you. Now the next question is from Aditi Mishal. She's asking, how do you see blockchain playing a role in improving health governance?
Madam, I really am not competent. Please remember, I'm a neurosurgeon with some familiarity. I don't know the intricacies of blockchain, but what general reading I have done, I know that blockchain is apparently it's essentially decentralization. Blockchain, I think, is more in healthcare administration. I don't see blockchain being used by a clinician. But the answer to your question should really go to our CIO or to CEO, CFO, etc. I'm honestly not competent to answer your question.
Okay, fair enough, doctor. The other question that we have is from Lipika Ahuja. In case AI takes over the healthcare sector, what would happen to medical negligence liability? Who would be responsible for medical negligence?
Very good question. I object to the first part of the statement. I don't think in the lifetime of my great-great-grandchildren, AI will take over. It will be a sad day for the entire humanity if AI takes over. And I'm sure, I hope it's not going to happen for the next 50, 75 years. Now, the second part of your question, it's very interesting point you have raised. There was an editorial in the New England Journal of Medicine about 6 months ago or 8 months ago, addressing precisely what you said. The answer again is, unless there is a test case in court, nothing is going to happen. No rules are going to be framed unless there is a test case. Apparently, it has just come in the US. You know, the US primarily is a litigious society. So somebody filed a suit that error of criminal negligence, etc. So the doctor defended himself by saying, I only implemented what was recommended by an FDA-approved AI system. Now, the question is, so for the judiciary, for the judges, does use of an AI system, approved AI system, absolve you? Does it take you away from your liability? Does it take you away from your decision process? So we don't know. Answer to your question is we don't know. And I don't think insurance companies in India, at least for another for 10 years maybe, I don't think they are going to specifically mention in your malpractice indemnity coverage that this will include AI. Neither are they going to say, if at all, they will say this excludes AI. So we are in a stage of transition. I don't think anybody can answer your question, but if you just Google, you will find there are several papers already published, intellectual discussions and all this. So these questions have been raised. I'm sure in a couple of years, there's a test case. Unless there is a test case, so far as India is concerned, I'll guarantee you, we are not going to pass any rule. All these are gray areas. For 20 years, the Telemedicine Society of India, which I partly started 20 years ago, we have been struggling to pass regulations. We are just not succeeded. So these questions are not going to be addressed. It's not black or white. It's going to be gray all the time.
Thank you, Doctor. The next question is somewhere related to your answer just now. It is from Manish Sharma, who had asked you a question before. Currently, there are no laws around telehealth. With this, because of this absence, what are the best practices you would suggest new remote health startups should follow to enable telehealth services? Your top 3 or 5.
Okay, I was asked this question. I so vividly remember 1998 when I gave my first talk on telemedicine. I was asked this question. I was asked this question just about 10 days ago when I gave a talk in Udaipur, I think. And the answer I give in the last 22 years is the same. I don't know. Now, having said that, I don't know. The second part of your question, the good news is, unfortunately, the media, see that everywhere in the world, the media thrives on sensationalism. Unless the sensational news is reported, the media cannot survive. So a lot of rulings given on individual cases by the High Court of Mumbai, for example, has been misquoted, totally out of context, and an unnecessary paranoia has been created because of this. What do I do? What do I tell my staff to do? What do I tell my department to do? A, record everything. B, I expect my doctors to be mature enough to say, sorry, the pictures are not clear, the audio is not clear, the video is not clear. I cannot give an opinion based on the information given to me. C, I need to do a rectal examination. Unless I do a rectal examination, I cannot give an opinion. Therefore, I cannot give an opinion through the video conferencing. You have to physically come to me, etc., etc., etc. So each patient has to be, decision has to be taken individually. Now, no court all over the world, particularly in India, please remember, no case ever goes to court even because of a wrong decision, a wrong judgment, even if a patient dies. I was a practicing neurosurgeon for 42 years. I've had several deaths. Maybe some of them I cannot exclude my responsibility, but not a single person has gone to court because the doctor-patient relationship. This is what I've been telling from the very, very beginning. So long as there is a good doctor-patient relationship, a patient does not go to court because of bad results. Let me repeat that 100 times. No patient goes to court because his near and dear died, because his near and dear got paralyzed, etc., etc. He goes to court because you have antagonized him, irritated him, made him angry, not communicated with him, never told him that this is a possibility which may occur. So this going to court is highly theoretical. It depends entirely on the doctor. The doctor must be so good. He must be able to communicate with the patient so well that the patient will sympathize with the doctor if an adverse event occurs. Okay. Coming back to the real world, we get, of course, the court has said that getting disclaimers is not an excuse, but nevertheless, we have a very simple disclaimer. It's not really a disclaimer, which tells you that there are limitations in the remote healthcare, and then please, as far as possible, direct face-to-face contact is essential. But because for various reasons, a face-to-face contact is not essential, we are promoting healthcare. For review cases, again, as far as possible, the first consultation should preferably be a face-to-face consultation. Note consultation should be given only on the telephone. With the see, the courts have said that you need to make a clinical diagnosis before giving a prescription, which I totally agree with. Now, I get so many consultations for headache. Now, as a very experienced clinician, senior neurosurgeon, I ask dozens of questions, and if I have the slightest doubt that this headache could be because of a brain tumor, this headache could be because of a hemorrhage in the brain, etc., etc., I categorically write in my case sheet, NYD headache, not yet diagnosed headache, or headache to be investigated. And I tell the person, I record everything in the case record, and I tell the person who is 2,000 miles away, please go and see the nearest neurologist or neurosurgeon. You must get this done, you must get this done. If I'm 99% sure that this is because of a fight he had with his mother-in-law yesterday, I would perhaps prescribe paracetamol, but I would also say, come back to me after 48 hours. So all this can be avoided purely on a doctor-patient relationship. So most important thing, record everything, document everything, and don't irritate the patient. There'll be no legal problems at all.
Thank you, doctor, for the detailed explanation. Now we have a question that if a fresh medicine graduate wants to provide telemedicine benefits in a rural community, whom should he contact to get started?
I wish there was a simple answer. I mean, there are so many ifs and buts, raising funds, what is your budget, this, etc. But anyhow, as one of the evangelists of telemedicine, I'm now talking not as a member of the board of directors of two Apollo telemedicine companies. Forget Apollo. Apollo's got nothing to do with. I suppose you could always send us a letter, and somebody will tell you what is to be done, how to go about it.
Okay. Now we have come to the end of the webinar, and we still have a few more questions, but what we'll do is that we will write to Dr. Ganapathy separately and then seek the answer and communicate to the participants. And we'd now like to thank you.
Thank you, Dr. Ganapathy. It was a very, very informative session, and I'm sure that all the participants would have gained from your experience. Thank you so much, sir.
Thank you. Thank you.
And thank you all the participants for participating. Have a very good day. Thank you.